We're literally less than 5 weeks away from the largest single open enrollment period of time for health insurance that we've ever seen in this country, and that's going to be the October 1st open enrollment for the exchanges. What we want to do is take you through what's happening with the health insurance marketplace and the exchanges in particular to give you a flavor for the market and what the impact is going to be. The new health insurance marketplace, and specifically the exchanges, really is a transformational, almost disruptive change in the entire insurance industry and the way that Americans have traditionally had obtained and kept health insurance. What you see is really for the first time moving to an individual market where people will going online, similar to booking travel or hotel through Travelocity or Expedia, going into the exchange to actually enter in information and begin to get very specific information about what subsidies somebody may qualify for, and in addition begin to select a plan that works for them. Now, the exchanges are really a part of and one of the more significant additions to the Accountable Care Act, which is now well over 3 years in the making. And through the Accountable Care Act, we've already seen insurance and coverage enhancements, really access impacts, changes to Medicare, and important testing, delivery, and payment reform. And many folks on the call are probably aware that you've got age of 26 coverage on parents' policy. You can no longer have exclusion for children with pre-existing. Preventative services really were introduced across insurance in 2011 and 2012. And last year you began to see the various press releases about medical loss ratio rules and consumer rebates. Medicaid expansion was supposed to be an integral part of the Accountable Care Act. The Supreme Court made it a state decision, and we'll talk about that in a minute. There are also other less known parts in terms of improving primary care provider support and also access to alternative types of services. In Medicare, we've started to see the filling in of the infamous donut hole, and I think one of the most interesting and exciting aspects of all of this is really the innovation grants that are coming out of CMS, and these are grants to organizations, institutions, and collaborations that really are looking to improve quality, lower cost. And if we think about the Accountable Care Organization Pioneer Program in 2011, that's a great example of how that might work. Well, let me give you just a quick high overview of exchanges by the numbers, and by the numbers explain a little bit about what's going on here. 7 million. Well, by some estimate, that is the number of people who are expected to pick a plan through the exchange in 2014. And I'm going to give you some additional numbers shortly on what it's going to look like as we look out over the number of years. 10, this is an important and actually critical piece. The 10 essential health benefit categories that are mandated as part of exchanges. And this is the first time where you begin to get this kind of consistency across plans on the individual market, where historically often there was not maternity care, often there really wasn't a pharmaceutical benefit. Important here is that prescription drug is a essential category and benefit that's integrated into the total medical package of an exchange. More to come on that. $2,000. That's the deductible that's expected in one of the bronze level plans. Now, this is where we have, across most of the plans, a deductible that's fairly sizable, although will vary. And I think we'll keep that in mind as we talk about exchanges and benefits down the road. The other important feature, not only in the exchanges but across all of insurance, is the annual out-of-pocket maximum of $6,350 for a single, $12,700 for a family, indexed to inflation and, of course, indexed to cost. This is the maximum out-of-pocket that's intended that a person will be liable for total medical care, and within the exchanges, certainly drug is included. So we'll have some comments about that. 70% of the benchmark plans for which were a basis for creating the exchanges are blue-based, or Blue Cross Blue Shield-based, and again, more on that a little bit. When you begin to look out over the next 8 to 9 years, one of the figures that I thought was fascinating is the amount of retail drug spend increase due to healthcare reform that we wouldn't otherwise see, and that's $26 billion. So certainly for those of us who are in the business or in the industry of creating and selling drugs, this is certainly attractive. What we see with exchanges is that there's really three different major ways that exchanges are going to be set up. They have the opportunity to pick a state-based where the state will pretty much manage it. If they didn't do it, it would default to a federal, and then there's a number of partnership programs. I don't want to get into the details of this, although anybody who looks in certainly the red and blue, any similarity to a political red and blue depiction of the United States is probably not coincidental. The core functions of the marketplace, again, depicting this across state-run, state-federal partnerships and Fed facilitated, really are in the five major functions of eligibility, enrollment, customer service, plan management, and financial management that are really critical to pull this all together. And then this is obviously creating this both at the federal level and at the individual state level has been a challenge, and probably everyone on the call has seen some of the news about it, and I'll talk about that in a little bit as well. But these are all the critical pieces of how it comes together. This is also a very scary slide, particularly anybody who's done project management within your company. This is how it works. This is the system connectivity and communication complexity that the new exchanges will have. So if you think about any of us going in to the web portal, we first have to deal with eligibility. And you can see all the different agencies in the government and elsewhere that need to be connected in to assure certainly eligibility status, resident status, and then of course you're tying in all the different tax information, etc. And actually income, modified gross income, is a critical piece here that begins to determine level of tax subsidy and also assistance that's available. And I'll have a detailed slide on that in a bit. What you're seeing in the news now is some concern as to whether all these connections are going to be ready or not by open enrollment on 10/1, and how all that will work. And certainly there is some concern as people are finding that this is an impossible timetable in order to really have all the appropriate testing in place. So, you know, my view is, as somebody who for decades has put in programs and dealt on the plan and insurance side with eligibility, it's going to be messy, but it will eventually work. Then you get to the shop and compare. There's online calculators. Then you have the entire enrollment process that then needs to connect between Medicaid programs and all the different plans and the interfaces and the data that goes in between. A very complex system that is certainly, as it unfolds, is certainly fascinating to see the development and how it will all work. Well, on an individual basis, basically, the exchanges will be available for folks who are not covered under a current insurance plan, particularly a large employer insurance plan. Obviously, for folks who are citizens, they're not in jail, and they meet various residence standards as well. The other piece to keep in mind is that there's the individual eligibility and then employer eligibility, and this is the Small Business Health Options Program, or SHOP. This is for specifically small employers, really defined as 1 to 100 or 1 to 50, depending on how the state does it, that allow employers and gives them tax incentives to really get their to buy insurance through the exchange, and I'll show that in just a bit as well. The other part of the rule and regulation here is that for a plan needs to go through a fairly rigorous process to become a qualified health plan to be offered on the exchange. So you have to be certified. There's all sorts of regulations that are there. You have to offer a gold and silver plan, and again, it has implications for what you do on and off the exchanges as well. So this is a part of it. What you're beginning to see now, particularly for the state-based exchanges, is they're starting to announce who their qualified health plans are and who the participants are going to be. We don't know that yet on the federal side, which is obviously the majority of states. So the deadline on that is September 4th, so we expect by the end of next week things will get very interesting as we learn who are the players that are going to be involved in all of this. I want to go back to the essential health benefit benchmarks. This was important to begin to establish for the 10 essential health benefits, what are the specifics and particularities by a state basis for which these will be determined. And so states had the option to recommend a plan that would be the benchmark, and there's criteria for it that you see below, or it went to a default. Well, at the end of the day, what we're finding is that the states are split about either recommending a plan or moving to the default. At the end of the day, most of the plans around the country that are benchmarked were small group plans, small employer group plans, which I'll point out for those of us who deal with pharmaceuticals, a lot of small group plans are fairly unmanaged pharmaceutically, so I'll just lay that as kind of a foundational base. 2 state employee plans and 4 commercial HMOs, and here's where we begin to get to the company breakout. As we look at the benchmark plan and the formulary, talking about that in a moment, 35 states were blue, 2 were Kaiser, 4 were United, and the rest were split among a number of different players itself. So let's talk about prescription drug benefit for a moment. These final rules were literally, they were finalized at the end of February, which gave plans less than 3 weeks to turn around a formulary build, submit it through their organization to be rated, and so that the submission to the state or to the feds could take place on the deadline at the end of March. An incredibly aggressive timetable. What the rules are was that the formularies on the exchanges need to include 1 drug in every USP category or the number of prescription drugs in the benchmark plan for that particular state. And then again, the plans have to submit this in for review and for approval. For those who've been around or follow Medicare, USP categories and classes, exactly what was used when the Medicare formulary built for the Medicare Part D program. The difference there is Medicare required 2 drugs per class. In this particular case, the differences are, though, that under the exchanges, there are no protected drug classes in the exchanges. So under Medicare, there's 6 protected drug classes. Basically means plans have to include every drug in that particular class. That doesn't exist here. There are a number of other fine elements that differentiate Medicare and the exchanges. So the exchanges begin really look begin to mix between a high deductible health plan that you'll see in the benefit design shortly, and kind of some of the rules that Medicare, the plans have been using for Medicare. Certainly plans do need to have an appeal process. This is pretty standard across most commercial benefits, and there is no limitation in terms of tiering or other utilization management tools that are there. We'll get more into detail, and I'll use some illustrative examples as we get into the slides. Let me talk about membership gains, losses, because this is really, what this is all about. The whole goal with accountable care and the whole goal with exchanges is to reduce the number of uninsured, make insurance more affordable, and improve the quality of care that people are getting. It's certainly laudable goals. This is a somewhat, could be a confusing slide, but I'll point out probably 3 columns. That's the Medicaid, the insurance exchange, and the uninsured. You'll see 2014 and then moving out to 2023. And the last column I wanted to point out, when you look at the curve going out over the period of 9-10 years, where you see it begin to level off or where we begin to see the maximum effect. So when we look at a potential increase in 9 million people under Medicaid and a potential 7 million folks on the exchanges and a drop of 13 million, please, when you look, you're seeing that these numbers are likely or at least projected to increase, probably peaking out over the next 3 years, somewhere between 2015 and 2017. So we don't have to look out 10 years for any of this. I'll also point out numbers change, and you'll see all kinds of things in the news that numbers are up, numbers are down. Certainly, we will continue to see that play out as we begin to better understand people's behavior about whether they're going to go into the exchange or not. More slides on that. A couple of interesting things, the projection about who's going to be the new exchange member. You have to understand that about 70% of people who are projected to join the exchange have not had insurance before. So it's kind of a whole new game. And when one has projected out their demographic profile, although they they do self-report that they're in great health. I think most people have said, well, if they haven't had insurance, they probably haven't had extensive workup, so is there a lot of latent disease here that we'll pick up. The important thing is language and educational attainment. Almost 20% of the folks, English is not going to be a primary language. That compares to about 12% of people currently in commercial insurers. So that could create a challenge to systems for which communication, even when English is a primary language, is somewhat challenging. And any of us who have been through the healthcare system and have English as our primary language can certainly attest to that. Almost 80% of the folks do not have a college degree, again, pointing to either a challenge and an opportunity about how do we best engage and communicate with folks, both in terms of who are newly insured, to get them through the process, all the way down to drug information and product information as well. There is a gap reality that started to that has taken place and that's starting to be realized, and that is with the Supreme Court allowing discretion for the states not to expand Medicaid. There is a gap in coverage, particularly in some of the large states who elected not to expand, that a fair number of people who were anticipated to suddenly become available for Medicaid coverage will have will not have access to Medicaid, but they won't have access even to the exchanges. And it's the numbers that I've seen are somewhere between 6 and 7 million. What I think you're going to find is many of the states that are still grappling with whether they're going to expand or not, maybe doing some alternative arrangements. Many of you may have seen in the news today, Michigan has passed Medicaid expansion, which is certainly good news for the hundreds of thousands of potential eligible people in that state. So I just wanted to point out that gap, and certainly we'll see a lot of play around that in the years ahead. So how does this all play out? I mentioned there's two different ways that exchanges will be accessed, both through the small business side and then through the individual. So similar to the diagram that I showed before, an individual is going to go in, they're going to put in their financial information. That information will help calculate what kind of tax subsidy or support they're going to have. They'll then have a choice of what kind of product levels they'll have. And you've probably heard of the metals, bronze, silver, gold, platinum. These are actuarially determined levels of coverage that are low levels of coverage. For example, bronze is designed to cover 60% of anticipated medical cost, or basically population medical cost. And it goes up 10 points, silver 70, gold 80, and platinum 90% of coverage. And each of those will have price points and premiums associated with it. More on that in a little bit. Let me just point out to you as a benchmark, Medicare Part D actually establishes a 75% actuarial coverage level for the plan and 25% for the member. So that just gives you a reference point of where we're at with Medicare. Most commercial insurers are typically going to be in that 85 to 90% range. Catastrophic is a unique category for people under the age of 30. Who are exempted from the mandate or otherwise won't cover. So once a person has picked what level of coverage might work for them, then they get to see who the carriers are that they'll have. And I'm going to give you a lot of slides that will kind of show how that's going to work. Similar situation on the small group side, except the employer is going to select the level of coverage, and then the members can select who's offering coverage in that particular state. I think you saw that there was a delay for 1 year of the implementation of that through the federal system, although many of the state-run programs will have small group options available in 2014. This is a way of beginning to try to add a little clarity to what is a very confusing process of two levels of subsidization that people have access to. It is anticipated that, again, 70 to 80% of people getting coverage on the exchanges may be eligible for premium credit, and this is an income-based tax credit, and a scale of 100% to 400%. And it's always interesting to see, for most people who've never had to deal with what is a federal poverty level, if you haven't been in this, both the governmental space, I showed you both a family of 4 and a single for 2013, 2014, gives you a sense of where that income is or who would be eligible. the cost-sharing assistance is another component of this, which is relegated just to the silver plans only, and it's designed to lower out-of-pocket costs, particularly for the 100 to 250%. This becomes important because two things. People don't understand what's going on with the exchanges, and there's just another survey out today that 50% of folks have no clue what this really is or about. And there's a potential for sticker shock. Sticker shock being when you see what the premium is, it's easy to say, there's no way I'm paying that. But recognizing that in many cases, some people, if they choose the right metal, may actually have a zero premium product. And some folks may be able to lower their out-of-pocket maximum from $6,300 down to about $2,000. And that's what that cost-sharing assistance really is. This is a slide that kind of shows a bit about kind of that sliding scale with different federal poverty levels and different income for a 25-year-old. It differs. There's age band. And some states have allowed increase in premium for smokers, for example. It's very limited in terms of how much a premium can increase according to the demographics. And there's also regional differences even within a state that could impact premium. But at any rate, you see here that out of a $282 or so premium, somebody could pay as little as $19 a month, or it may go up to paying the vast majority of it, and that's with one plan. If they pick actually a cheaper plan, they could actually get it for nothing. And this is another way of describing the benefit. And why it looks a little bit different, or as I describe this, it looks a little bit like a high deductible health plan for those of you who've been in high deductible health plans. It also, as I said, has some of the regulatory or requirement features of Medicare. But here you have that premium, again, $321. It could be a month. Scary number. Again, a lot of people have never had insurance before, and you saw the income levels. The real question is, are we going to scare a lot of folks off? Again, recognizing that the credit or the premium credit could, in fact, bring that down to very affordable levels, if nothing. The deductible, depending on the metal, could be $2,000 for bronze. It may only be $250 to $500 for a platinum. It's going to be variable, but again, a deductible means more out-of-pocket. Out-of-pocket max, you see, as an individual. Obviously, it increases for a family. That can change. But you're going to expect to have various levels of copay according to the metal. So you might find, for example, here a generic copay for $25. This may be the silver plan. It may just be $5 if it's platinum. So you'll basically see that kind of fluctuation in benefit design according to the metal level. And I'm going to give you some examples, very specific examples in two states in just a little bit. So at any rate, with 5 weeks coming, this is a huge issue. We are seeing the exchange blitz. And I expect right after Labor Day, those of you in selected states will see a ton of this stuff going on. We've already seen, at the highest level, the president and the secretary of HHS at press conferences, national events, talking about it. Navigators are really a part of this, the whole Accountable Care Act. Over $67 million has been used to fund the hiring of navigators who will help people through this particular process. It's been a little slow to start. The requirement for training has dropped from 30 hours to 20 hours. Hopefully, this will come on, will align itself and truly be of assistance to people. Brokers are certainly a key part of this, particularly with the small group piece of it. Community agencies and partnership, we're talking about everything from church groups to not-for-profits. A good example, New York State is contracted with over 50 community agencies to be in front of people and do face-to-face counseling about signing up for insurance. And now we get into the favorite part of this, which is really the over $100 million of advertising and promotion that's going to be used and started in some areas and will really intensify. We're looking at TV ads. We're looking at Facebook. We're looking at YouTube videos. In fact, HHS has a competition now to kind of, have people create YouTube videos to raise awareness about insurance. And it's all about getting people's attention with unique sites and opportunities. And I'll point out a few interesting ones, a few creative ones. Washington State has just launched a $26 million outreach program. They really want to hit the young, healthy people. You have to do that in order to make sure that you don't end up with a high-risk pool of sick people who are just going to drive premiums up. So their feeling is, okay, let's get the people, and where do young people hang out, and what are their needs? Well, they basically need to charge their phones. So they're looking at sponsoring and putting ads on phone charging. Connecticut, for some reason, has picked a beach theme. They've actually have Cover Connecticut, kind of a catchy little logo that they're putting on sunscreen. They're also doing flybys over the beach with banners and promotion on this. Minnesota has just launched about 2 weeks ago their $9 million campaign using Paul Bunyan and Babe the Blue Ox, kind of iconic figures in Minnesota, up in Minnesota. And this is it's depicting Paul Bunyan in a variety of different situations that is supposed to have people ask themselves, you know, geez, I probably should have insurance now. I don't know about you. I look at this and say, I'm not sure I'm as stimulated to go online to sign up for insurance than I am to go online and put my sled on Craigslist. And certainly, my favorite so far is going back to the state of Washington, who said, how do we get to the young, the invincibles, the people we want to sign up? Well, we have to be active and we have to be visible where they are, at rock concerts, at festivals. And so they came up with the idea that they're going to sponsor porta potties at these kind of events. Well, at any rate, I'm a student of advertising, and I have to admit I do get a kick out of how people's creativity runs wild with all of this, and certainly we'll look forward to seeing what you see in your state when the advertising blitz comes. Well, let's talk about, for a minute here, let's talk about the impact that the health insurance marketplace and the exchanges have for all the different stakeholders, and it really impacts everyone. And this is, as I mentioned, is a huge transformation. Really a disruptive part of insurance itself. The implications for the individual is coverage versus penalty decisions. Again, there's an individual mandate. It is required that people have insurance. So you're either going to have appropriate, acceptable coverage, or there's a penalty. And that penalty for 2014 is the greater of 1% of your income or $95, and that graduates up over 2 years. To $695 or 2.5% of income. So that, you know, the implication is, well, is it better, is it cheaper for me to get insurance, or do I pay the penalty? There's been a lot of discussion that, quite frankly, the penalty is probably not enough. You know, $95 for a year, it comes out of your taxes, is not a whole lot more than any person's 1 month cellular phone bill. So there is a concern that we have not, there isn't enough stick in the game here. People are going to have to navigate exchanges versus private insurance. And I think I depicted some of that for you. Considering people have not had insurance before, there's multiple features and choices that are made. It can be complicated. They're going to need to understand the subsidy impacts and the processes and how this informs a decision about what they do. They're going to have to select a plan. They're going to need to pay premiums if it's not zero. And again, there's a lot of discussion of what happens, you know, for folks who have not had this before, and quite frankly, most people, and particularly employer-based, have paid through payroll deduction and not as their own monthly payment. So again, this becomes part of an issue, and then who's liable for the costs and what happens if a person doesn't pay their premiums. And overall, an individual is going to have to assume greater control over their health care spending and decisions. As a piece of it. And we see that when there's new dynamics, new co-pays, new deductibles, and there is some skin in the game in terms of what you're going to be paying for. For employers, obviously there was a delay for the large employers in terms of their pay in this, that there's not going to be a penalty for large employers until 2015. There is a reduced incentive to offer insurance in some cases. But at this point, it's not believed that most large employers are really going to abandon the employer-based system as is. We may find that there's certain segments, low income, part-time workers, the retired workers. It could be the existing COBRA kind of people who've left employers, for which that might be the first grouping for which there's a transition to a new model, i.e. the exchanges. The small employers have to decide what they want to do. There's lots of rules and regulations. There's lots of data that has to be assimilated and reported, particularly if they're going to be claiming the tax break, and it can be up to 50% tax break for a small group employer in 2014. And then this long-term decision on continuing employer-based coverage. You've already started to see in the news UPS announcing that they'll no longer cover spouses and others that have other insurance. So again, I don't think you're going to see a radical change right away for the large employers, but this is going to be kind of this evolution of how this transforms over the next 3 to 4 years. What about the poor providers and physicians and healthcare system that's here? What's interesting is what you're seeing is narrow networks, limited narrow networks may become the norm in the exchanges, particularly as a lot of the plans have offered more HMO product. A little bit, you know, there are obviously PPO products as well. But there's going to be increased price sensitivity that plans are going to have as they compete in this marketplace, in a very transparent marketplace where your price is compared to others, and it's going to bring new reimbursement challenges. What about the credit and collection challenges with high cost share? In the benefit design for folks who've not been used to paying for this. Again, a challenge to provider systems who've really not done all that good a job from a business perspective of collecting and assuring that they're solid on this. I alluded to the demographic changes and what that means in terms of establishing effective communication. All of this is taking place on the overlay of multiple parallel transformations and evolutions in care delivery and finance that's going on, obviously accountable care. So a lot of challenge and unknowns here. For the insurer, as I open, this is the largest open enrollment season in history. We're talking about, even at the low end, 5 to 7 million people. That's a huge number. There's $200 billion of premium that's out there for the taking. However, there's new underwriting rules and regulations. There's new risk, low margin. There's rules about how much margin an insurer can have. Anything more than 3%, they have to turn back in to the government to help fund risk programs. They can't rate the same way. They have no idea of who to expect into the pool. So there's a lot of unknown, although, you know, it's kind of that finding that sweet spot between the enthusiasm and excitement about this large pool and these dollars of premium and the very scary side of not knowing what you're going to end up with and how it's going to work. It's also a change in business model from traditional group and sale model to a retail and individual market. Very similar to what Medicare went through. Medicare is an individual market. Many health plans have separate Medicare divisions that aren't tied to the commercial side because they are so different. And you've already started to see health insurers set up storefronts in some states to really begin to focus in on this consumer-oriented. And importantly, price is transparent. And you've got these unique and diverse segments that you're going to have to work with. What about the manufacturer? What we're seeing here are a number of interesting, what I'm going to call challenges and opportunities. We're going to see an increase in the number of people insured with drug coverage. Remember, there is not a carve-out situation here with exchanges. If a person belongs to exchange, drug benefit is integrated into the overall medical package that that person gets and managed by that plan. And so where you have a lot of situations where employers may carve a drug benefit out to a PBM and they don't talk to each other, they're not really related, they have separate cards, that's not happening with exchanges. But you're also going to find here with exchange, if a person goes in to enroll and they qualify for Medicaid, they go into Medicaid. There is not a choice there if, obviously, if they qualify. And so you're going to see increase in Medicaid members, and that's going to have a challenge relative to the business model that you have, knowing how much work and effort typically Medicaid tracking and reporting has. The other dynamic here, and scary aspect is, as income changes, eligibility could change, and therefore people up to 30% of Medicaid enrollees into the new process could bounce between non-Medicaid, exchange, eligibility, and Medicaid. And so there may be this a lot of churn, and there's a lot of discussion about how to minimize that, but we're going to have to keep an eye out for it. The exchange benefit design could result in an increase in direct out-of-pocket expenses for some members. You saw deductibles, you see co-pays. Certainly, if there's not a good understanding of eligibility for assistance and how that might work, you may see a barrier to entry, to even getting on the drug. But recognizing the new rule about capping out-of-pocket is, to me, one of the best protections for consumers that I've seen in a long time. As somebody who has been working with, drugs since the 1970s and dealing with the affordability from the insurer and community side, when you deal with an average specialty drug that's over $2,600 per month per member, and you see that that's the wave of the future, these new benefit designs will protect people after that degree of outlay. So I think one of the things that we're beginning to talk to manufacturers about is, what does this mean for patient assistance program and indigent programs? And I know what you're thinking. You're thinking, well, what about Medicaid and Medicare? We can't do copay assistance program. What about the exchanges? And there has not been any regulation that has come down yet specific to that issue. I won't get into a lot of it. There's a lot of differences, similarities and differences between exchanges and Medicare and Medicaid, but I believe that at the end of the day we will not see that regulation. I could be proven wrong, but so far there's nothing that has that we can point to. There's also going to be variability in formulary coverage, and again, it goes back to the benchmark plans and the formularies. Let me give you an example. Obviously, each state has a different benchmark, and it's based off of their individual plan. I just wanted to give you a sense of the kind of variability that we're going to see here, and I've picked just 10 drug classes, recognizing there's 157 of these, and when I look across the country and I see what's the lowest number in a benchmark plan of drugs in a category that have to be included on the formulary, and what's the maximum, you see that difference that is there. And again, the rules that we say is that a plan, if you're going to be offering a qualified health plan in a state exchange, your formulary has to have a minimum of 1, and that's where you see the 1 in parentheses. For some reason, the benchmark plan had 0, and I think it was an interpretation difference, or the maximum number that a plan might have. So I wanted to point that out. There's variability. The other impact is we finally have an integrated medical pharmacy benefit coverage and focus at the plan. And so medical and pharmacy are working hand in hand. And so the management of drug across, whether it's infused in the physician office or in the outpatient clinic, or it's a drug that's obtained from a specialty pharmacy or a retail pharmacy, they're going to be viewed at and managed as a cohesive program and plan within that plan. I think the opportunity there is an opportunity to really begin to collaborate, and therefore, if, for example, a drug has an opportunity and a value proposition that can lower overall healthcare cost, you now have, with the exchanges, a captive audience that is more receptive to that message than they were in the more traditional commercial model, where those two aspects were really siloed and not tied together. So we're going to see an increase in demand for product value documentation. We're going to see where this is important for favorable position, and there's going to be increased demand for aggressive pricing strategies, as you'll see in a minute, as plans really look to drive their costs down in a transparent model so that they can get membership. So what's the learning curve on all of this? Well, first is, what's the positioning? New opportunity, challenges. Do your existing drugs make the cut? Do they have to add your drug? Is there opportunity for repositioning here? What about the different formularies? Most folks who deal with the market have to deal with a Medicaid formulary, a commercial formulary, and a couple versions of that. And now there will be the exchange formularies that will look different and may be different than the commercial formularies. And even the same plan or parent company who offers plans in multiple states will have different formularies for different states. And my colleagues across the country have been pulling their hair out, those who had any left, that basically said, you know, I've now created 8 new formularies to market across the regions that I'm in. New drugs. Maybe more difficult to get on formulary depending on the class and the minimum number of drugs. As I said, benefit designs may impact drug utilization. So that's an overview of the impact. I wanted in a couple of minutes to talk a little bit about and show you an example as we begin to pull some of the data sources together, and if we're following this very closely, how it begins to inform decision-making and behavioral that you're going to see in the marketplace. So I'm going to highlight really 2 states, California and New York, 2 large states that have a lot of exchange potential, have a lot of Medicaid expansion potential and reduction in uninsured. So in California, the benchmark plan is Kaiser. There were 13 plans approved. It was the first state to approve plans and make it very public out there. Since that time, one has dropped out. This is going to be a very fluid period of time. Many plans have decided for a host of reasons that they're not going to compete on the marketplace. I raise this only because there are plans here that folks who are traditionally in the commercial space may not be familiar with, plans that have only operated for perhaps in the managed Medicaid space. Now I want to show you a slide. It's a little bit confusing, but I'm going to point out 3 or 4 key points of how exchanges are going to work and why it's changing the behavior of plans and what you're likely to see as behind some of the pressures from the pharmaceutical manufacturing side. I picked one region in California. Not all 12 plans are going to be offering, or companies are going to be offering plans in each of the regions. It may vary. Sometimes it may only be one region, sometimes all. So I picked one region. There are 19 in California. The LA region's got a lot of folks eligibles in it, and you see there's 7 plans here that are going to be offered, and you see the different premiums across the bronze, the silver, the gold, and the platinum. I also indicated at the federal poverty level what the cost would be because of the subsidy that is there. Now, the subsidy is calculated off of the second lowest silver plan offered in that region. So you see Blue Shield PPO here at $252. That's the basis for which the subsidy or the tax is calculated. So if a person picked HealthNet HMO that's coming in at a lower price, they're going to pay less than that for silver. What you're also going to find, if the subsidy is $132, if somebody drops down and gets a bronze plan, they're going to be paying less than that bronze plan. If they want a higher plan, like a silver, gold, or platinum if offered, they're going to be paying more out of pocket. So that's how that works. The other thing I want to point out to you, look how transparent this pricing is. This is what's different. This is a very visible pricing that's going to drive a competitive side of the companies depending on what their position is in the market here. We've already seen when these have been published, plans have gone back and have readjusted their premium rates because they're not positioned exactly where their strategy wanted them to be. So here's the rub that's going to basically kind of trickle down. The competitive aspect of being in that sweet spot from a premium perspective, and when an individual goes up and looks at what plans are available to them, and they're going to be ranked just like Expedia by cost, where do you want to be? And therefore, you're going to drive your vendors and your suppliers to drop your costs, protect your costs, you're going to be low. That's the new dynamic in the marketplace, at least in health insurance that we will be in. New York State is fascinating. Again, it's an area that I'm very, very familiar with. Probably the most plans that will be participating in an exchange that we have seen so far. The final list was approved just last week. Interesting, Aetna is not on this list. It was on the prior list that they had. Again, you'll see name changes or names that are different than people are familiar with. Not all plans are offered in all regions. In this case, in New York State, the benchmark plan is Oxford EPO, which is a United plan. Again, a very similar picture that what I showed you before. 5 players in the Rochester, New York area. You see pricing that's a little different, but again, not quite as clustered as it was with California. I want to point out this to this market, in particular, that two insurers in this market owned literally 85 to 90% of the market in the insured group, and that's Excellus and MVP. What you're seeing here is the lowest cost player here is somebody that nobody has heard of in this market, and they're also lower cost, also called freelancers. And so the interesting question here that we begin to ask ourselves as we evaluate who are the key players that are going to be in the marketplace is how are folks positioned from a pricing perspective. And I think is my theme here is you're going to see price competition demands from the plans, and you're going to see players emerge that may not have emerged before. So if I look at a strategy insight from New York, you see new players. For example, you see freelancers also change its name in some areas, National Republic Insurance, and they're being offered in a number of different states. A lot of managed Medicaid plans like Fidelis Health First Metro Plus are moving into this commercial space. Why? They want to capture those folks and keep them in the folks who basically start vacillating between commercial and Medicaid. Plans selling out of their usual territory are generally less competitive. The large national players in general tend to be priced higher in the market. And what's interesting about the New York benchmark is that in some cases it will really derive formulary expansion for many participants in some of the key categories. I want to point out this other example here in Oregon. Again, just point out another interesting point. A lot of key players have set up subsidiaries to be available, as they're offering on the exchanges. So you'll see new names. Bridgespan is going to be, Cambio, or the old Regent, or part of the Regents family. Primera has the LifeWise program. And you'll see in this case at least 1, 2, 3, 4, 5, 6 new players within the Oregon system. So again, new players, new challenges, new drugs on formulary. So what are we seeing as we begin to distill this down? Really, fluidity in the market. There is no question. Every day there's something new that's going to be taking place. There's new regulation. And as we saw with Medicare, we expect this is just the start. As we gain more experience, there'll be new rules, new regulations, new anticipations. I fully expect within 2 years we will see star rating on the exchange program. I fully expect we'll see quality metrics that will be a key part of who can participate and who can't participate. It's now a reporting requirement, but we'll soon move to those kinds of things. State, plan, and provider approaches to managing all this, again, will continue to evolve over time. We have a lot of unknowns, even though we're very close, to this thing, becoming going live. Plans, participants, benefits, formulary, memberships, data, all of this is really going to be coming available in different formats and different ways, and continue to be updated in literally over the next year or two. I mentioned the September 4th deadline. That's when the federal exchanges announce the QHPs. It will really be the fourth quarter before we begin to fully understand the formularies and the benefits. We'll know open enrollment will start through October through December. Actually, the first year open enrollment will go through March of next year. There will be some tech glitches for sure. The question is going to be is when are we really going to know membership numbers? It took a long time in Medicare to figure that out back in 2006. People were still doing reconciliations 6, 7, 8 months into it. And I think it'll be 2014 when we see drug utilization impact. We're also have got this concomitant healthcare financing, delivery, and care reforms that are taking place, and how this all fits into the strategy and the attention span of people who are dealing with multiple things going on, and really the realignment of stakeholders and changes in their incentive structures and new engagement rules. So there's a lot going on here across the industry and boiling all the way down onto the drug side. Again, preparing for the event, this is a new emerging area. The pharmaceutical manufacturers will need to adopt new guidelines, have to take a look at compliance requirements, particularly on the Medicaid side. The real question becomes, what do you do with a sales force and account management? Are there new relationships and new entities that currently haven't been on your radar screen? Some of the large players have been prominent in the Medicaid space. are they bringing their limited network and their management approach to now this growing population, and what does that mean relative to your strategy? Value demonstration. You know, I mentioned that a lot of folks were really under pressure under the first year to get their formulary out. We expect that there's going to be a lot of focus, you know, looking at the 2015 strategy. So as we get into the first quarter of 2014, I expect we're going to see companies hit with way more proposals and requests than you probably have been prior to this time. Only because of the people were just so focused on getting this out the door. A lot of states said if you're not in the game on 2014, you're going to be locked out for 2 years, and the next time you can get in is 2016, so there was that additional pressure. More of your book of business are going to be under price pressure, and we may need to revisit the current patient access schemes based on the new insurance rules, the new out-of-pocket maxes, and what the allowable amounts are. So with all of that that's going on, I just wanted to mention that one of the things that we have done is that we've put together a comprehensive product that really looks at bringing together 4 related arms of data services, consultation, education, training, and services support that is really designed to pull all this together and to really tackle this evolving, confusing marketplace on an ongoing basis, and to really help, you know, our clients out over the next number of years to really, you know, take advantage of the opportunities and to help build in very key strategic and tactical solutions into your planning. So I wanted to mention that, and certainly for folks on the phone, we would encourage you, please follow up with us if you would like more information about any of that. So with that, I have gone very quickly through 40 slides. It's probably time for me to take a breath, since I can't hold my breath for this length of time, which should be no surprise to you, and certainly invite you to submit questions. And Art, I think you're also going to be opening up for people to actually ask a question.
Hi, Joel. First off, great presentation. Thank you for that. Very informative. I do have some questions here for you, so I'm going to just read these off, and I'll let you field them. Mm-hmm. So, first question is, what will the impact? What will be the impact on wholesalers and drugstore chains?
The question on wholesalers and drugstore chains. I'm not sure I can, well, let me back up at a higher level and address that from the issue that we're already seeing about limited networks. What we're seeing with limited or restricted networks is really more, at least this first year, on the medical side. I think it is not going to be any great surprise that as plans begin to get to that right price point, is that we begin to look at plans begin to look at how do they design their pharmacy networks to take advantage of or leverage better pricing and costs. And I suspect you're going to see more drive towards potential mail order for chronic drugs. You're going to see a drive towards limiting specialty drugs to specialty pharmacy. And I think in that particular case, and I think the third arm of that certainly could be leveraging selected pharmacies within your network to take advantage of a better price point. I honestly don't see that that's going to happen at any greater degree in the 2014 offerings, but I would suspect this is going to be something that we can all expect for 2015 and beyond.
Okay, great. Next question here. With a combined medical/pharmacy deductible in the healthcare exchanges, do you anticipate that infusion drugs will more often be covered as a pharmacy benefit?
It's a great question. The answer is no, because there's really no need to cover it as a pharmacy benefit. And I think we may be talking about semantics or definition here. It doesn't have to be covered under the pharmacy benefit in order for it to be integrated into the cap or the maximum out of pocket. And part of that is because it will get aggregated, think of it as a medical arm and a pharmacy arm, and whether a drug is, for rheumatoid arthritis, whether it's Remicade or whatever the drug is, an infused, or it's a self-administered, those costs will get aggregated at that next step up. The challenge when we talk about covered quote under the pharmacy benefit is that many of the provider contracts and reimbursement rules make it very complicated to be able to do that without totally pulling the drug out of the office, without disrupting, basically in some cases better GPO pricing. It's a fairly complex area. I don't see, in a simplistic way, I don't see that necessarily as a drive. What I do see is that the people who are managing pharmacy typically are expanding to have accountability to manage the medical infusions and the self-administered drugs as one cohesive policy, strategy, step therapy, prior authorization, et cetera, et cetera.
Okay. Next question. In a therapeutic area like CNS or SSRIs, how will a decision be reached on which generic to go with?
I suspect the question is on a generic, and quite honestly, I think most folks will likely include all the generics anyway, unless there is a high-cost generic, and I think what you started to see a number of years ago is kind of an additional generic tier. So you had two generic tiers, so it was the low cost and then the higher cost. I think if there is an opportunity to limit, and you have the opportunity to limit a generic drug, that's maybe where it will go. I suspect a lot of plans have not put a lot of focus on managing generic drug utilization when in fact there just hasn't been that kind of cost impact to do so. On the other hand, as the number of drugs, if there's 19 drugs in a category and you can meet it with 19 generics, I suspect you're going to see plans going the opposite direction of not wanting to limit that in any sense.
Okay, next question. Will state exchanges have a centralized posting of QHP drug formularies?
Great question. We suspect that they will. And we suspect that it will be similar to what eventually evolved with Medicare, in that, one of the important features in choosing a plan is to be able to go in and evaluate a formulary in terms of your coverage. And on the Medicare side, it has gotten sophisticated enough where in fact there's the ability for people to put in the drugs you're taking and it will spit out what the best formulary is for you. And I expect we are going to get there. I don't think it's going to be on the list of functionalities that people will have by the first of the year, but I suspect that will be there. This is all about transparency. And we will expect it may be not as easy a functionality in the first year, but we are expecting transparency in the formularies within the fourth quarter of this year. And it's one of the things that we're going to be tracking within our data services is the specific formularies, drug placement, and positioning in each category as part of our program.
Okay, and I've got one last question for you here. You mentioned the generic copay on the silver plan may be around $25. Any insight into the possible brand copay?
Yeah, that was just one example. I don't even want to presume that's not a standard, that's not a requirement that you see. You're going to see the same kind of range that you're seeing across the board for on the commercial side. What happens is copays get played around with a lot to meet actuarial value that needs to be met in order to meet the standard for either a bronze plans, etc. Along that line, I would expect, similar to commercial, you're going to see a range of, let's say, second tier or preferred drug being in that anywhere from $25 to $40 range, and you're going to see third tier probably being in that $35 to $70 range, depending on, some of the states may have particular rules or regulation about capping some of that as well. So that number, it's going to be variable, and again, we'll please don't look at that number as that is a standard that's there. As I expect, we will see the same kind of range that we are seeing across the board. And I would expect we're going to start seeing coinsurance as well in some categories, particularly in the next generation of benefit design within the exchanges.
Okay, and that's all the questions for you, Joel. We did get the question. We did get a couple people asking if we're going to make this presentation available, which we will. So we'll be sending out an email to all attendees, most likely tomorrow morning, and you'll get access to all of that. So I think that about wraps it up. So Joel, thank you once again for a fantastic presentation. I think everyone found it really insightful. I think we had some really great collaboration here at the end on the questions. So great job, and I think everyone have a great afternoon, and that's about it.
Great. Everybody enjoy the last couple days of summer.
All right, take care, everybody.
Thanks.